Yeah. No, they're always
Sir.
welcome back. You're not stealing them. They are there for the use of everyone who needs one. Yes. Sorry, we're clarifying a paperclip situation here. So we're back and we have Dr. Hildebrandt from Vermont Department of Health with us, and we're starting to go over budget and governor's budget recommends. So I'm going to start with you. You're the first person in.
Great. This is 2 for 2 in the House, with being in that seat. So great. For the record, Rick Hildebrandt, Commissioner of the Department of Health. Thank you all for having me. I'm going to be sharing this presentation with Megan, who will give much more of the in-depth financial information than I have, but I will give initial introduction and high-level overview. So our mission and vision and values, again, present these here, and I want to keep these in a lot of our slides just to, again, reconfirm our commitment to Vermonters, that we stand by them in this changing landscape despite whatever happens on the political landscape, both federally and locally. Our departmental structure, we have 616 positions across our central office, 12 district offices, the office of the chief medical examiner, the warehouse, our lab. Again, a reminder to myself and to us all that we have a wide range of things that we do. Some of them are very much public health and looking at where we live our lives and the health of our environments. And other ones are very clinical, like the Office of the Chief Medical Examiner, do nursing home visits, laboratory testing, and the like. We have experts in all these fields that I rely on heavily because, having been in the seat for less than 4 months, I am not the expert in all these areas, but have been getting rapidly up to speed, and I'm very thankful for people I have in that. Another slide, another thing we do love data. We provide a lot of data and reports to the legislature and other places, including the State Health Improvement Plan, State Health Assessment, Healthy Vermonters 2030 Dashboard, and many, many, many others. These are mostly links for your reference, and just to say, hey, there's other things that we do besides the programmatic work around data. So, our budget process this year, we did very different. It was my first time doing it, but it was done very, very differently than the years past. Instead of looking individually at our own departments, we looked as an entire agency at the amount of money the agency spends, where it's going. It was a very interesting process and frankly helped me rapidly not only make very close connections, but also understand the programs in the various departments within the Agency of Human Services. It was challenging too, because we knew it was going to be a tight financial year. This year, we're looking at a $75 million deficit within the Agency of Human Services. And when you look at the landscape of all the things that we do, there are some that are very important that we had to look very critically at, including services to Vermonters, including occupational therapy for people with disabilities. I mean, things that you do not want to let go of. So in the grand scheme, when we're looking at that, keep that in mind when we're talking about some of the cuts that are in the Department of Health, because we did have to weigh those against everything within the agency.
May I interrupt?
Yeah, of course, anytime.
Within AHS, $75 million in cuts. That's not, is that federal money?
It's the entire budget, not just federal money.
Did you say cuts or deficit?
GF.
It's
Oh, it's
GF.
GF. I'm sorry, GF. I apologize.
Cuts or deficit?
We'll let Megan go into the details of places. It's not all programmatic cuts. Okay, just to be clear, it's reductions in the budget. Here is our pie chart of where all our funding is coming from. Again, the majority of our funds is from federal funds. And the budget for the health department is $221 million this year, which is a 1.2% overall decrease from fiscal year 26. Again, federal funding is the largest source. General funds only account for 11% of our total budget. and the general fund share of the budget plus the state share global commitment is 22% of our budget. We have a $5 million lower budget request this year than last year. And our federal receipts are projected to be $1.1 million less.
I'm sorry, 1.1 less?
1.1 million lower for federal receipts and 5 million less in global commitment budget.
Okay, Lori?
Can you explain the difference between federal fund and global commitment?
I can. I promise you, Megan will give you a better answer, but global commitment is through the 1115 waiver from Medicaid that we share with the state, roughly 60-40 split between federal and state funds, whereas federal funds come a lot through grants. So we have a lot of grant funding that we get directly to the department for a variety of programs. Like heard the news last weekend, the FIG funding, the Public Health Infrastructure Grant, which is very important to us, comes from federal.
Okay. And I'm sorry, I know Chair Black already asked this, but can you clarify those information numbers again?
Yes.
5 million, the 1 million.
So $5 million lower global commitment budget
Okay.
and 1.1 million lower in federal receipts.
General fund remaining the same?
General fund is lower.
General fund is also lower.
Yeah.
Yes.
For the
Regarding-
record, Noel Lamb was at this office. It gets confusing, but it shows up, it's matched in the AHS central office. So that's where the general fund and the federal fund, they will find it in the departments, it's global commitment. That's why it's global commitment. So to the commissioner's point, most of that federal fund that they get directed to grants. Sometimes departments do have direct federal funding for other things, but most of the global commitment piece are matched, and that's why it shows up as the growth.
So,
Yeah, go ahead.
so by reducing state funding, we're obviously reducing any global commitment
Depends on where
match.
it's reduced from. Depends on where it's reduced from. That's a Megan question. Wasn't it?
Okay, so we'll let you keep going in that. Okay,
Yeah.
thanks.
And the main thing that I do want to present is the programmatic cuts that we are proposing, okay? Because those are ones that are meaningful and speak to some. So 3 programmatic cuts, 2 are in the workforce training bucket, 1 through the AHEC program support, and another 1 through health professional educational assistance for VSAC. And then discontinuing the efforts to implement the unused drug repository program. I will go into all of those high level on the unused drug repository program. We got no bites when we tried to do this. It wasn't enough funding really to do the program. I don't actually think the amount of money that if we were to actually fund it fully, I think we would make less money than what we would get out of the drugs if we just bought them. It's just a very expensive process to go through unused drugs, sort them, repackage them, and distribute them to people. So we didn't get any bites. Yeah.
Are we gonna get into that
We are.
a little bit more further? Leslie, do you want to hold your question?
I'll hold mine too.
Yeah,
Okay. So
I think he's just giving us a preview slide.
yeah. And again, the next 3 slides are on those 3 individuals, so programmatic reductions we're looking at. So the first one the proposed budget would end the healthcare professional educational assistance programs through University of Vermont statewide area health education centers and Vermont's Student Assistance Corporation. This is a UVM program that is funding basically tuition reimbursement for healthcare professionals. It's not the only source of funding for VSAC, but it is a chunk of money. And the reasoning behind this is a couple of reasons. Again, the prioritization of the funds throughout all of AHS. There were other programs, again, service line programs that were felt more important. But the other piece is the Rural Health Transformation Program has a significant amount of funding that's going to be funneled into workforce development, more than twice this amount of funding. We're going to be looking at investing in workforce development, and we would like to reimagine that program, how we're doing it, to get outcomes that basically encourage and have outcomes that show people go into healthcare in Vermont. That's what we want to do. the outcomes of these programs are not horrible, but they're just not where we want them to be. And if we think if we rebuild this program, we can have better outcomes. And frankly, expand the programs to have the right service professionals in our state. As an example, yesterday I was doing a tour in the community health centers of Burlington, and they've got a wonderful practice there. And part of it is a dental practice that is really great. They don't have any dental hygienists at all. They can't find anyone. So they're not able to service many people. Things like that would be great to look at when we're rebuilding these kinds of programs to make sure we're training and providing the right healthcare professionals. Anyway, so we see this as an opportunity to reimagine the way we're providing tuition reimbursement not tuition reimbursement, excuse me, tuition assistance to students to build healthcare.
Yeah.
Yep.
No, Lori, did you go first?
Is there more on that?
The next one, which is related, is around AHEC,
Okay.
which is a supportive program to that, but this is the on the.
Okay, so I'm gonna wait till AHEC separate, okay.
Yeah.
I think my question is, we know that the rural health transformation funds come particularly around the workforce development, that it comes with a lot of strings attached and how and who it can be dispersed to, that it can't ever pay, tuition that has already been incurred. It's not a loan forgiveness. How does the very narrow way we can use those funds, how does that differ from what VSAC and AHEC currently, their model?
Yep.
And are we leaving a big gap?
Yeah, that's a great question. I can't give you a full answer because I don't know the full answer of that because
Okay.
it's been challenging to work with to find all the exact strings associated. The big one I do know, we cannot use it for two things. Can't replace something we've already got. So we can't just say, we're going to just replace this with federal funds. It's great. Yeah. And we can't use it for specifically tuition reimbursement. We can use it for a tuition scholarship programs. So you can pay someone scholarship while they're in school. You can have the strings attached to those monies, which we absolutely need to do. I am confident we can build this program in a way that serves Vermonters and frankly has better outcomes than what we have now. The retention rates being better, the outcomes I'm looking at. How many people stay in Vermont for how long in the right fields? But you're right, there are strings attached to it. 100% agree with that, and it's a different program than this. There's no way to say that it's true.
The money that we invest currently in these programs,
Yes.
do they have a federal match to them? And are we going to lose that federal match if we are not putting in state dollars?
I do not believe so, but
So for the record, you might call it financial director, we'll definitely get into this when we go look at ups and downs, but yes, some of the programs are global commitment funded.
Okay,
So the cut includes both the state, as Nolan was saying, the state funds and the federal share, which is.
okay.
but I think also, correct me if I'm wrong, we're not decreasing the amount of drawdown of general commitment, global commitment funds. It's not like we are taking less funds from the government in totality in the state of Vermont. It's just not coming from this program.
We're reallocating it somewhere else.
Correct. And that's that process that we were looking at within AHS is where should we be spending this money? And it's less in here and a bit more in here.
Go ahead,
So
Laura.
sorry, I'm gonna have
No.
questions. So
Okay,
a couple,
please.
one, just
Yep.
on that, I'm going to hope that when AHS comes into the central office, they will show us that alignment.
They show all of that plus highlights on specific programs like this across the entire agency.
Okay, and if we're reducing, if the recommendation is to not have these programs anymore, what's happening to the people who are currently receiving money?
You're absolutely right. That's a gap. I mean, again,
They're just gonna lose the money that they've been told they were gonna have.
So the specifics of the program, I believe it's not a you are guaranteed this money for X number of years. It's more of a you apply for and get this reimbursement for this year. So there wouldn't be any more money into the program. So they wouldn't have funds next year as an example. So there are people who are currently receiving tuition reimbursement from old loans that wouldn't be able to have it next year.
Okay, so can we get the data? You said outcomes aren't great. So can we get
Yep.
the outcome data and
Yep.
can we find out the parameters of when people
The
sign
hooks.
up.
Yep.
The hooks.
Yep.
And then my other question is, and I could be completely wrong about this, so
Yep.
correct me, but I believe this budget was made before we received the rural healthcare transformation. So what, so this decision was made before that, I believe, and if so, are you already creating a plan as to how to replace this as of July 1st?
So the application.
Was
when-
submitted.
Right. So we had submitted an application for tuition reimbursement. You're right, it was a gamble, because we weren't guaranteed that we were going to get 195 million, but, there was confidence in the program. This is some before I was
Yeah,
there, that, we would get some money for workforce, development. And frankly, I think we got more than we thought we would.
Okay.
Our hope was we were going to have similar amounts of funding within this bucket, but again, I stepped into it a little bit midway through, but my understanding was there was a acknowledgement that we were hoping to get money from this, but wasn't guaranteed.
And I'm going to admit on record that I have not read the rural healthcare transformation plan. So could you also send us the piece that talks about what the plan will be for workforce in that?
Yes, I can.
Thank you.
And to be clear, information about this is rapidly evolving at this time. So we'll send you what we got now.
Okay.
But I might want to send you some next week too,
Perfect.
and maybe the week after, because it could
Absolutely.
absolutely change in those intervals of time with more specifics, okay?
you.
Budgets and things of that nature.
Thanks.
And I just want to say, we'll probably talk to VSAC, AHEC. I want to be clear, though, this is not, we're not replacing.
And not replace.
We cannot replace.
And people will
And-
be affected by this. It's true. People will be affected by this.
Yeah.
In a negative way and in a positive way. Having more funds sounds great, but when it's not going to necessarily go to the same people. Again, my hope is, yes, this is a change and this will be hard. And for many folks, myself included, I'm hopeful that we can build a system that is better and at the other side.
But we haven't done that.
We have not done that yet.
Have we started?
So again, the rural health transformation.
We just got the money.
Yeah, no, and that's the thing. The rural health transformation work has really just started. It started in earnest, really recently. So I am very acutely aware of the time frame on this, and I have been talking with my folks and with the secretary about making sure that we can build this quickly, because you're right, we got no
That's a
time.
lot.
Yeah, we're against it.
Alan,
Can you just kind of explain to us this transformation money? It's going to the agency of human resources. Then all the agencies get what their wants and
Yeah.
wishes?
So high level, in the application, we submitted a number of proposals for things that we wanted to do. Okay, and there's, I don't know, more than 24. Okay, they're not all within one program. There is certain things within the application that says, here's the things we will do, and you can sign up for them in that sort of way. So as an example, within the health department, I'll speak to myself because it's what I know. There are things within mobile integrated health, within community paramedicine that we apply for and we've received positive on. So, working on building that system, redeveloping that system. Things in education are another one, and another one in recovery residences. So those are sort of some of the buckets that fall into our shop. There's a whole lot that is central office. And then there's pieces within other departments as well. So it's not like I get to ask for things. It's the application has things in it that make sense for us to apply for.
okay,
All right. So again, in the same sphere, AHEC, which is, a supportive program through UVM, our recommended budget cut would end the Global Commitment Funded Grant, which is $500,000, which provides operating support for the state area health education centers, which is to promote healthcare local college, high school, and middle school students, and a $50,000 annual grant to AHEC to recruit UVM medical students and medical residents to work in Vermont. Again, same thing. These are really challenging discussions and choices, but our hope is that we can rebuild a system that is stronger on the other side. Yes.
Could you speak a little bit louder when you tail off?
I'm very sorry. Probably because I'm not as excited about this as I am about other things, to be frank. But just, so the budget would end the global commitment, funded grant education, which is $500,000 that provides operating support for the state area health education centers. The focus of those centers is promoting careers in healthcare among local college, high school, and middle school students. Would also end a $50,000 annual grant to UVM's AHEC for a program to recruit UVM medical students and medical residents to work in Vermont. So those are the sort of specific programs that we are recommending to NOLA. And then the last one is the state prescription drug repository program. Again, this is one I briefly touched on. This is a program that was designed to collect unused prescriptions, resort them, package them, and provide them to Vermonters who need them, which is a great idea, I think, on paper. I think when it came to actually doing it, it was just too costly. And the amount of funds that was appropriated to it, we just could not get any bites on it.
Talk about bites. You said bites a
The
couple.
RFP, we had no one to take up our RFP. No one submitted an application.
In Iowa, I mean, there were other states that have,
Yeah, go ahead, because I know this was your bill.
Yeah.
It was.
I remember this was your
it
bill.
was very exciting at the time.
Yep.
Yeah, and there are other states that are very successful in this
Yep.
program. So what's the problem?
I can't say for sure, but I could say the problem is the funding amount. That's what it boils down to, is it the amount of money that was in the appropriation is not viewed by people in Vermont anyway as something that they could do. And I don't know for sure why that is. I suspect strongly it has to do with the resources in Vermont, and that is a real challenge that we struggle with, is just having enough healthcare workers in different fields. So in the realm of pharmacy, having worked as a physician, I know we are short on pharmacists, we are short on pharmacy techs. Those are resources that are challenging to come by. If I were to venture a guess, that's what it is, but I don't know the specifics other than it's funding. It's not funded at a high level.
So all the problems that this was supposed to address, which were a lot, are just gonna go up in smoke.
I wish that we could get a partner to say, yes, we can do this for this amount of money.
But why not ask for more money? I mean, if we believe, at the time, we believed in the program.
Yeah, again, we could certainly do that. We could appropriate more money. My strong guess is if we just bought $400,000 worth of medications, it would be more than the amount of money that the pills that we're throwing away. Because the value of the meds themselves matter, right? So if we spent this money and just bought money, pills.
What is it? I'm sorry.
$355,000.
Okay.
What year was, and what did we appropriate in that?
2025 was the appropriation year.
Okay, so it was in FY, we passed it in 24, so it was in FY 20. So how much did we appropriate in FY 25?
It's $355,000.
Okay,
It's been out for RFP since then.
so it's just been sitting in a bank account and now you're giving it back.
It's not been funded.
Was it in base?
If it was general fund, so we have it in ups and downs. We'll go through it in
Okay,
And just again, this was the agency-wide budget process, as they were looking at all programs across all departments. This was one that was not currently implemented.
Correct.
So the agency executive leadership team figured it would have less of an impact on. It's not enacted, so it was a
great idea, but it would cost more to administer it than it would be to just buy these drugs.
That is my that's my guess in looking at the funds here. I know that it's not enough that someone's willing to take up the program. And again, to Megan's point, one of the things we did look at is, hey, what hasn't been implemented or what has been underutilized when we're looking at where we can trim. This was one of those.
So may I ask, how many, I mean, how much of an effort was actually put into it? How do we?
I can't speak to that.
How do we know?
I do know
I mean, Brendan, I'll just say Brendan Atwood and I worked together on this. This is before he moved up to Ladder, but, and he was pretty excited about it at the time.
we posted an RFP. I do know the division that was working on this within the health department posted an RFP to get interest to see, what vendors were available. I don't know the exact results of those RFPs or who, responses, but there was effort put into trying to find a vendor who could do this.
But certainly no one ever came back and said there's enough money to implement the program yet. Even though it had value and it
Correct.
came from you.
Correct. I don't deny that there's a lot of merits to doing something of this nature. I think it's a financial problem in terms of how much money that it's costing versus what someone is going to charge to do it. And frankly, I think, again, as I said, I think the value of the meds themselves.
So then it's better to just incinerate them, which is what's happening now.
As horrible as it is to say, because I don't like to make waste ever as a Vermonter, financially, that's probably true. And I'll say strictly.
And then it's going into air.
I know. And I'm not, there's a whole bunch of other pieces with this that, right, have costs associated with that. I'm saying dollars and cents, though. I think there's a challenge there. Any other questions initially before I pass it over to Megan? Again, I know that none of these are programs I frankly want. I don't. Okay. I like them all. And this has not been pleasant, I don't think, for anyone, certainly not for me stepping into this. It's always hard to talk about budget reductions. I know the team did their absolute darndest to try and minimize the impact of the monitors, and I can see that book here.
My initial question is, we had a joint hearing with Senate Health and Welfare and Human Services. Just Human Services. I'm sorry, getting my around restructuring of AHS.
Yep.
And one of the identified things was, and we just had a witness who, the co-occurring substance use and mental health.
Yep.
And the highest recommendation was that alleviate, and we're having. It's one of those days, like a third one. I should plan 3 minutes where everybody can just get all their sounds out.
Yeah, let's see.
So I'm curious, I don't see anything reflected in the budget on sort of more of a sharing services between DMH and VDH. Because I thought we were trying to come together on some of our programming.
Yeah. So as it pertains to Act 119, my understanding is we would need a legislative change before we would do that, would be in the following fiscal year if that were to go through. I can speak to the work that we've done because I've heard feedback from the designated agencies around this. I've experienced it myself. There is absolutely a lot of folks in our state who have co-occurring illness. And I have worked diligently with Commissioner Hawes to make sure that whatever gaps currently exist, whether it's challenges in operations or legislations or just teams coming together, we've worked very hard on that. We've actually done a lot of great work to make sure, regardless of what happens, structural change or not, we're going to meet the needs of Vermonters who have co-occurring illness and the agencies who are delivering those services who have been struggling. So the financing of that, I believe, would not be until the next year. But again, right now, I'm not going to wait for that to make sure we have a great system of care for these folks.
All right.
I'm going to pass it off to Megan. And I will still be here if there's anything, of course, that I can answer.
Ups and downs, which we all understand 100%. No one gave us a tutorial.
Again, for the record, Megan Hope, Financial Director, Vermont Department of Health. I believe you've all gotten a copy of the full AHS ups and downs, but in the event you didn't.
No.
Oh, hey, I'm sorry. We have, that's why I threw them in as an appendix. The last kind of, or the first 3 slides of our appendix is kind of that full, lovely spreadsheet. But I do have, once AHS gets those to you, we have reference numbers for pages. So just as a brief review, the health department has 3 different appropriations. Our admin and support appropriation, which includes the commissioner's office, our Office of Health Equity, our public health appropriation, which is our largest. You can see we have many divisions within public health, and then our substance use program appropriation. Oh, yeah, see, Nolan's got it. No. So the public health appropriation, this slide represents, this is the changes in our gross salary fringe costs from fiscal year 2026 to 2027. So again, all of these lines here represent gross changes to position costs from year to year. And I'm happy to take questions as you've got them, or I can just keep barreling through. Can I just verify that it is actual fiscal year 26 or is it budgeted fiscal year?
Budgeted fiscal year 26.
So,
Or, yeah, we, this is 27, but the comparison is to. Comparison is to 26. Yeah, budget. Yeah, budget to budget. Yep. No actuals anywhere. Correct. I'll keep going on then. This next slide shows one last change to our personal services section, the workers' compensation insurance that the state pays for. And then the operating expenses, you'll see these are changes in our internal service funds. So fee for space, our buildings, other employee insurances, our ADS costs. You'll see that line is rather large. That's the $1.5 million change. Our understanding is it's a change in the way ADS is going to be billing costs to the agency and departments compared to this current year we're in. There's going to be less costs billed to the AHS level. So in our BAA, we have that ADS allocated service charge that usually fluctuates. The intent is for less of that and more of the billing to go straight to the departments. So AHS will have fewer costs, the departments have higher costs, and then we just won't have to do that transfer mid-year. That's the intent.
Go ahead, Lori.
So the intent, so when will that start? Fiscal year 27 is my
On July
understanding.
1st.
Yeah.
Okay, so so right now you're saying that it's all at the AHS level?
There's a mix. A
Okay.
majority of our billing is to that AHS level, and then AHS allocates out to departments. We do have some direct costs to ADS based on if there's a health department specific project, or we have, ADS staff working on very health specific things. Those get billed directly to the department, but these are kind of those broader charges like support desk services, Microsoft Office licenses, the very broad general IT support.
So do you as a department get a summary or I'm not sure what I'm trying to say, like a data sheet that says what you're being charged for, that you know that these are all things BDH has?
Yeah. Right now, that broad summary for this ADS allocated charge goes to agency services. So because that's kind of how it's been dealt with in the past, that summary will go to them. My assumption is now that we are budgeting for it directly to the health department, that will come.
And so do you know if the charges that they're sending down to the departments now are truly based on the department's charges, or is it kind of like we have 5 departments, we're looking at equal?
I believe AHS does a review of that and then an allocation based on usage or staff. I admittedly can't speak to exactly how the AHS office then allocates it, but thanks. Yep. Any other questions on this?
Yeah, Brian.
I don't know if you're gonna get to this later, so if you are, we can wait, but I was just curious if you could say more about increases related to people going back to work and having to pay for spaces that we weren't paying for before.
So the health department budget does not have, these are just increases in fee for space and rent that are just general for spaces that the health department has already occupied, no
It's like
impact.
the COLA or whatever.
Yes.
Yeah.
Yeah, this is just
Thank you.
the 3% rent increase that BGS is anticipating for currently owned,
Thank you.
or currently occupied.
Does that fee for space also include things like paper towels, toilet paper? It does not. Is that reflected anywhere?
No, right now, this is assuming, this was, when we built this budget, it was the current level of staffing that the health department has at our various locations. So district offices, our public health lab, our central office, which will be expanding in Waterbury, but for right now, this was our current occupancy before.
When you say it's expanding, do you mean like you anticipate people returning to the office or are you moving into a new space or is there construction? Like
The health department is anticipating a larger footprint at the Waterbury.
within the facility?
Yeah.
I see. Their space is gonna be reallocated.
Yes.
Okay, thank you.
I think that's why Diva had to move out.
Yes.
EGH is taking their desks.
You gentrified Diva. I'm kidding. Thank you for laughing and understanding. It was like not meant to be offensive.
So sorry if my laugh is inappropriate.
These are ups and downs, not base. If you want to know how much they spend on paper towels, that exists in a bigger budget book where they allocate to so much we have for this, that, and the other thing. What this is saying is we don't plan on buying more paper towels than we did last year, just to kind of use that as a reference point.
Even though more people are there.
And they'll come budget adjustment, and they'll say we need more toilet paper.
Yeah.
Or like those newfangled devices that dry your hands.
All right, let's,
All right, moving on.
This last section in our public health, our admin appropriation is the grants changes. So the first three lines you'll see here reflect the move of our rural health and primary care program activities from our admin appropriation into public health. So those three lines were not program service eliminations. We're just reorganizing where the work is done within the health department. And you'll see corresponding, when we get to the public health section, you'll see corresponding increases or ups in those lines. And funding levels are, as again, I said, unchanged. It's kind of a net neutral with it.
Laura, I'm sorry, Leslie.
Else, could you just talk about the quality improvement prescribing I know it's net neutral, but what is it?
The Quality Improvement Prescribing Program, that's a budget for 2 grants to the statewide area health education center for academic detailing and education programs for healthcare professionals. That is funded with our evidence-based education and advertising special fund. And it was, I believe, established, the program was authorized by 18 BSA 4622.
So what does that mean?
Yep. The academic detailing program is a university-based prescriber education and support program. Faculty reviews clinical topics focusing on the latest evidence, lifestyle changes, generic medications, and new drug releases. And it's shared with healthcare teams across the state.
So is there any data about the impact of the program? How many people participated, changes in prescribing as a result of the program?
I'm sure there is, and we could get that to you if you would like it.
Yeah.
Over the first 3 lines that are, again, programs moving into our public health appropriation. The next 2 lines, the Area Health Education Center and Education Loan Repayment, those are the 2 programs that Dr. Hildebrandt mentioned are proposed for elimination this year.
I want to be clear, these 2, I mean, I'm looking at them together, but the one is really just administrative support. The 550 is administrative support for AHEC.
I believe it is a combination of administrative support and the small program to help recruit.
Okay. Residency.
It's not a task.
It's not what?
It's not task or tuition, it's not a, tuition reimbursement.
How else is AHEC funded?
It's a big chunk of it.
Will they go away?
It should happen.
Yeah.
And then the last line, again, quality improvement prescribing, we talked about it a little bit, but that's another program that is just moving out of the commissioner's office and will be going into our public.
Yeah, I've got Nolan and Copper.
Go ahead, Nolan.
I might be getting ahead, but I see you have the education loan repayment, you're taking 250 out of federal funds, but on 312, you're adding it back.
Yep.
Is that, I see this quite neutral on the federal piece, but does that mean you're still funding the program?
Yes, so,
With 550 in federal?
yep, thank
You're
you.
still leaving some money for the
Yes, so our state loan repayment grant comes, I believe, from HRSA. That program is still maintained by the federal government, so that aspect of this broader program will remain. It's the global commitment funded part of the AHEC program, the education loan repayment that we're proposing to.
Do you have details on that somewhere?
Sorry.
It's showing
Showing
the amount, like what is staying versus.
Yes, what is staying is the $250,000 state loan repayment grant. And in our detailed budget book, you can see that's a federal receipt or an anticipated
Okay.
federal receipt.
So I'm sorry, I didn't realize we had a detailed budget book.
Okay.
we see that?
We haven't posted it yet. We're getting it ready for appropriation. So that's, yes, I apologize, but it should be ready soon.
I realize that we're still in negotiations, developing things. Is the intent to hopefully use AHEC as the administrator of whatever loan assistance program is developed using the RHT money?
VSAC is probably the primary mechanism of loan distribution. I think that's TBD in a way. The VSAC is, again, they get the lion's share of funding that we have for this loan forgiveness program.
Uh-huh.
So they're a large group.
Okay.
But I think it's too early to say exactly where.
I asked that very specific question as well, about where's AHEC in this RHP stuff?
Okay.
Should be better.
That was the
We stepped out of the room.
last change in our admin appropriation, so moving on to public health. This is very similar to what you saw in administration. These are salary and fringe changes net for the coming fiscal year. Let me know if there's any questions on these.
Absorb the numbers here.
Yep. I will say just in general, you will see there's a rather large interdepartmental transfer reduction there. That reflects changes in the way the preschool development grant is being administered throughout the Agency of Human Services. In the current year and the year before, VDH did a lot of work. That grant is held by the Department of Children and Families, and they provided a good amount of funding to the health department to do specific work and activities. The way that grant is being operated within the agency is just changing a little bit in the coming year. The health department anticipates doing a little less work, but DCF is continuing most of those programs and activities. So that's why you'll see a rather large decrease in the interdepartmental transfer fund at the health department.
This is an aside, but it's just the childcare contribution. Do state employees, I know that there's an option for employers to pay 100% of it, or it's like a 75-25 split if you want. As an employer, does the state of Vermont pay 100% of the childcare contribution, or
I know that off the top of my head. I believe employees pay a bit, but I would need to get back to you on that. And then the last change in kind of the personal services section, again, as Dr. Hildebrandt mentioned, is the removal of that the unused drug repository program from our global commitment budget. Then we have 2 lines for changes in operating expenses. Again, fee for space, that's our cost of our district offices and the public health laboratory. And then this medical and lab supply line, that is a transfer of a program of the Narcan distribution program from our public health appropriation into our substance use appropriation. So again, no funding changes for that. We're just reorganizing within the department where that program is maintained.
Sorry, it just seems like every time, this is a general question, every time people come to do the budget, there's always like these transfers. Why, like,
Is it because you're looking at things and you're like, oh, this doesn't make sense, or just curious what the rationale is?
Yeah.
Like, things constantly are moving.
So I can't speak for every department, but for the health department, you know, this past year, we did, the health department leadership kind of took a look at where programs were being housed and run, and it made sense to move some of those programs out of our administration division or appropriation, sorry, and into either public health, or in this case, moving our Narcan, which is largely a, you know, treatment of substance use disorder, preventing overdoses. It made more sense to have that program run out of our substance use appropriation. So some of them are just those kinds of internal moves within departments sometimes, and we have a few of these ourselves. When we're building the budget, we find areas where the budget isn't really true to how we actually fund a program. So there's some of those shifts as well. It kind of, the format of the ups and downs makes it so you see any.
Yeah.
change.
Right, yeah, no, it's interesting. Okay,
Yeah.
thank you.
I have a question about it. Does it? I mean, it feels as though if we're moving the money around, we're recognizing that things should be incorporated in different areas, which would imply a level of efficiency. And why don't we ever see? Why do we always see net neutral? Why don't we ever see increased efficiency?
That's a good question. Admittedly, right now, these programs, we needed we needed all of the money to continue the program within our substance use division. We might see efficiencies as this move comes, but we didn't want to move the program onto a different, you know, into a different unit, and then also at the same time short them. We wanted to keep the program whole and allow the new division to help to implement that.
It's more of a philosophical
Yeah.
question. We never seem to see increased efficiency and down.
I do believe, and I don't know the AHS wide presentation, but there are some program efficiencies in the AHS wide budget this year. As again, we looked at the whole of the agency rather than just department by department. I believe they were able to find some program efficiencies that they were able to book some savings from.
Point is valid. The point is
Yeah.
valid, and you're absolutely right. There is some examples of that, like with COVID era funding or emergency support that we had that funding away, staff. That's something that I've been asking very hard questions about with my programs, because there are some countries we have increased in size corporately, and if that funding either goes away or the world has changed, should we be looking at reducing back to the way things were back in? So you're absolutely right. That's something that is absolutely on my plate. It's looking at it's a challenging question for sure, but looking at a lot.
Leslie?
So you obviously been immersed in this budget for months. We are now seeing it for the first moment. Are you planning to give us a narrative? I mean, you're explaining a lot of stuff, but I'm not keeping up.
Yep.
I must admit. So I'm wondering if there is a narrative that you could support these recommendations, changes, whatever, to help us understand your thinking.
Yes, again, we're working on some supplemental materials as was requested through the Joint Fiscal Office and the Appropriations Committees. We are preparing those supplemental materials that will hopefully complement and help explain the changes in our budget.
And then you'll come back when we have that.
We could come back, it should be posted to the, it'll be posted.
We'll come back
but-
whenever you ask us.
I was gonna say, if you would like us to come back, yes, we can come back.
It's just really hard to tell for me, I'm saying.
Oh, yeah.
To take this in and be a responsible person. I'm not
Yes.
feeling that opportunity right now.
To be fair, I do think you have a chance to see the entirety of the AHS divisions, and they also spark.
I mean, you want our votes, right?
That's
a lot of
truthfully, we want you to understand it.
Tucker, go ahead.
This is just an information question. Suboxone. It's Suboxone an opiate?
How about I answer that?
I was gonna say, I'm gonna defer.
Well, that's what I'm hoping you do.
Yeah, yes. So, Suboxone is a combination of two different medicines. One of them is an opiate called buprenorphine, okay? And the other one is an opiate blocker, okay? And the rationale behind that is that if you just leave an opiate, people use it as a drug of abuse, okay? So by pairing it with a potent opiate blocker, if someone were to do things like crush it and try and inject it, it would block the effect of that opiate. Now, in practice, people still, to some extent, do that, but there are huge benefits with Suboxone. Obviously, we've seen those in reduction of opiate-related deaths. Can't overdose with Suboxone. That's one of the biggest advantages of the medication. Are there people who are using these medications in ways that are not the intended prescription? Of course, but the benefits of these medications just so far outweigh the negative effects. And we've seen that in not only here, but across the country. But that's sort of the rationale behind this, and it's been very effective. But yes, so buprenorphine, which is part of Suboxone, is an issue.
And the other part of the question was, and you become addicted to Suboxone.
So it's an opiate. So absolutely, any opiate can be addictive for sure. And there are definitely humans on this planet who that is the way they entered into addiction. Again, my clinical experience that is the far minus. Much more commonly, these are used as medicine as a bridge to sobriety. And the point is that there are people on this planet who have found pills and use them as a substance of abuse.
I appreciate that. I thought that's what it was, but I want to make sure.
There are.
Because we're using it in the treatment program,
Correct.
and we're using a lot of.
Yeah, that's true. We use it as a replacement. And again, clinically, what happens with Suboxone, we are getting very far away from our budget. And I promise you I'll wrap up very quickly.
Well, we're actually about to go into the substance use.
Yeah,
So
I thought you were there.
It is a stabilization effort. Okay, when someone is using drugs, injecting IV opiates, the brain chemistry becomes very, very dysregulated. When you have someone on Suboxone with a daily dose that's set and measured by a physician, the brain chemistry regulates, and that thinking can become very much normalized, and you can then engage someone in truth. That is the philosophy and what we've seen in practice with this medication. It is an opiate, it is addictive, and it is in some cases abused.
Thank you for that. I had
Absolutely.
an argument with somebody last night about it. I wanted to make sure I was right about
Did you win the argument or did you lose it?
it.
On a friend next time.
It was neutral.
It was me, okay.
This is the last slide for our public health appropriation. And again, you'll see these were a lot of the programs that we had kind of reorganized within the health department itself. So the move of those rural health system improvement, clinical development and support, and the healthcare quality assurance out of administration into public health. This education loan repayment line, that is the state loan repayment grant federal funds that is remaining. And then our quality improvement prescribing. So all four of those items that were taken out of administration, put back into public health. Oh, I lied. I have more on public health. Sorry. The next slide, there's a two-parter. We had a lot of grants. Our immunization program. So this budget line item represents a requested increase of 7.5%. In vaccine costs for the Vermont Vaccine Purchasing Program. As I'm sure you're probably familiar, the program ensures universal access to vaccines for all people in Vermont at no charge to the individual. And the program helps reduce the total cost of vaccine by using large purchasing contracts. And the program costs are funded with an assessment to health insurers, which is deposited into a special fund. And that is our requested increase in the special fund. We anticipate vaccine costs to be about 7.5% higher next fiscal year.
Can I ask a question, Nolan, here real quick? How do we assess insurers to go into that special fund? Do you know?
Which special fund is it?
It's the immunization.
The immunization.
Oh.
I believe it's a per member per month rate. That people, I will briefly speak to it, but we could get you more information, but we assess every year, there's a committee that reviews how many, reviews all the drugs or not drugs, immunizations that we're recommending. We estimate the cost of purchasing those, and then each insurer is charged a per member per month rate based on their covered lives.
In addition,
If we're increasing this by almost $2 million, are we using residual money that's in that special fund, or are we increasing the per member per month that insurers pay
This would be
into it?
This would be an increase in the per member per month rate that's charged to insurers.
Okay.
Insurers are on the committee that reviews the assessments and approves.
I'm sorry. So is this state money or is this money from insurers?
This is money from insurance.
That's coming in as revenue?
Yeah.
Okay, thank you.
That fund was created by this committee about 12 years ago.
Oh, good.
It's a great, I'm
I was here.
It's great, yeah.
I'm just trying to figure out, it's a great,
It is great, yeah.
and it's great cover.
Medicaid's
Yeah.
very novel, and many states are jealous about it. It's a wonderful, really wonderful.
And let's forget that the insurers are then not paying for that immunization if it's state supplied. And they claim for their member. Okay.
The next line is yet another internal kind of health department reorganizational change. This is related to our syringe service program that was previously part of our HIV/AIDS program. We're again kind of moving it into our substance use programs appropriation, just because it makes a little more sense for that program to be run out of that division.
Is that because of the policy changes over the last many years? Because originally it used to be that CDC money for HIV was funding the harm reduction efforts. Is that changed now? Is it coming from a different source?
This is specifically syringe service program, so we could never use federal money for syringe service programs. So this very specific portion, our HIV/AIDS program, is still living within the public health appropriation, but this is just very specifically.
Oh, you mean like the giving out of needles versus the bleach kits and the condoms?
Yes.
Okay.
Yeah.
So I'm sorry, where is that going now?
Substance use appropriation. The next two lines you'll see are changes to our maternal and child health programs. The very first line, this down in the interdepartmental transfer of 2.4 million, that is as I mentioned previously, the changes in the PDG grant. Again, a little less money is coming we're anticipating less money coming through the health department and more of those programs being operated directly by DCF. I'm sorry, preschool development.
Thank you.
Yep.
So we would find an up in DCF's budget.
I believe so, but it would show up in their side as federal funds, just because of the way so we don't count federal funds twice. It shows up in DCF's budget as federal and ours as interdepartmental transfer. And this next line under maternal and child health programs is the school Medicaid administration claiming is moving to the Department of Vermont Health Access. Then actually, I realize we're short on time. Do you want me to keep going? Okay.
Let's hit the highlights.
Yeah. So this next change in our tobacco control program is we are better reflecting how the budget is appropriated and how we spend it. And then the very last change in the emergency medical services, that is an increase of $300,000 in special fund. The source of that revenue is a transfer from the fire safety fund. Back in 2024, there was an increase to the annual amount of the transfer to the health department from that fund. So we're just kind of cleaning up to ask for that additional spending. No one's taking credit. Finally, our substance use programs appropriation, these net salary fringe changes. The biggest change you'll see here, and I apologize, I meant to mention it when we were in public health because you would have seen it there, but there were 11 positions that were in the substance use programs appropriation that worked out of our district offices. Those positions have been moved into the public health appropriation. They still work out of the district offices. They still do substance misuse prevention work. Again, it's kind of an internal alignment shift in the health department as to where they were funded. So that is the large federal.
So they're in the central office of VDH, not the central office of AHS.
They are VDH employees. They're out in the district offices, but we used to fund them out of the substance misuse appropriation. We've moved them to the public health because that's where our district office is.
Okay.
Our budget.
Got it.
And again, this medical and lab supplies line, this is the Narcan program that is out of public health into substance use. And then finally, we have changes to our grants appropriation and the substance use prevention account code. You'll see an increase in the annual appropriation. The special fund is from the substance misuse prevention fund. And that is the 30% cannabis excise tax that is transferred into the fund by finance. The administration is estimating that the amount of revenue available in 2027 will be 9.5 million. So our current budget, this is again where it's sometimes helpful to see that larger, big budget book. Our current budget is roughly 6.9 million. So to get us to that estimated 9.5, we've asked for an additional little over 2 million.
Why are we losing federal, or is it?
No, the total, it's a combination of a few things in this particular line. We anticipated additional special fund, and then our federal we're trying to true up the funding for that kind of program to how it's actually spent. We are not necessarily losing federal grant money. It's just we had more federal in the budget than we actually really use in that particular line. Substance use intervention. This is the new kind of what is the SSP program. So that syringe service program that was moving out of public health and into, it has a different label now that it's in public substance use. And then our substance use treatment account code, we again change in the kind of general funding mix of our programs. No overall change in funding levels, but we're trying to, again, better reflect how funds are going to be spent out of this program. So there's a decrease in general fund and investment global commitment, but we are anticipating being able to claim more of our substance use block grant in that for the treatment. And then very last item, and then I'll open it up to questions, is a transfer to the Department of Mental Health for certified community-based integrated health centers. So these were previously providers that the health department paid as Medicaid fee-for-service. They are transitioning to that community integrated health model, and that is held within DMH. And I believe they get a flat rate per member per month payment by DMH.
What did you just say about your block grant?
Yeah, so the substance abuse treatment line, we're not getting more block grant. It's not an increase in our block grant, at least not that we're anticipating. We're across this program, we're seeing trends where we're able to spend more of our block grant on substance use treatment. And therefore we can kind of true up our funding and spend less on treatment from our Medicaid investment. That,
Or we could just spend more.
that is the end of our budget.
Any questions? Okay, and again, we'll invite both VSAC and AHEC in regarding the loan stuff.
Yes.
Go ahead, Brian.
Would you say that loan change is the greatest change that you've presented today out of everything? It seems like it stands out to me, but is that the biggest change in terms of funding and policy that you're proposing? Okay, thank you. So with that,
That's what I do.
well, thank you.
Thank you.
Actually, I do have a question about that.
Sorry.
Because you sort of, I don't know if you directly said this, but, or maybe I just felt like you alluded to it.
Yeah.
We've put a lot of money over the years into particularly AHEC, or, I mean, I know every single year that I've been here.
Yeah.
Have we seen results in terms of workforce, particularly physician? Have we gotten good bang for the buck, or?
So that's the question. I can get you outcomes on some of the tuition reimbursement and retention out of that. Again, I think we have an opportunity, because if I go around to the primary care offices and say, hey, do you have enough primary care docs? I can't imagine a single person saying yes. Now, that's not blaming anyone, not. But I think we have an opportunity with this funding that we're having from the feds to say, is there a way we can do better? Because I don't think we fixed it. And I think we have an opportunity to maybe not fix it, but work towards it better. And that's my hope and my goal. So the extent to which AHEC, I'm sure that they can provide you specific granularity of what an impact they've made. But I think we can do.
What does that mean? What does do better to you? I mean,
to
because
me, yeah,
obviously
sure.
the implementation, you have, 5 years of funding.
Yeah.
And then it goes away. So what does do better mean to you?
Decrease the workforce shortage in Vermont. I mean, ultimately, that's what we're trying to do. Trying to decrease the shortage amongst the myriad of workforce, in healthcare that we have,
So
whether
what
it's.
do you do
physician-
differently than what's been done? Or what do you think?
We really need to move on because we're 10 minutes late for our
I'm
next,
curious about that.
our next witnesses, and, thank you.
Absolutely.
Thank you very much. I feel like I haven't taken a break. You know what, if anyone needs a break, they can get up and go take their own break. I'm not. You're adults, figure it out.
You can always jump on YouTube or Zoom and keep listening like I do.
Does anyone, I had copies of the up and down made.
Oh,
Now.
Hey, thank you. No.
Health department starts on page
Take one.
10.
Thank you.
Okay.
Yeah. No. And, or.
This is everything.
All ages.
It's taken here from this.
We're pivoting to, back to H585, which is what we were doing yesterday. Does somebody want to invite our next witnesses in? Because I saw them and I know that they're out in the hallway.
Yeah, I saw them like go come in and escape. Or maybe be more like scooped away by the healthcare advocate.
Hi, and we are live, just to let you know. Anyone else want a copy of that?
You got one.
Earthquake.
Oh, wow.
You guys can come on up and have this anyway. You're on first.
That was like Star
We're
Trek.
not taking a break. I'm making people work through. So again, we're pivoting back to 585. And we've asked Green Mountain Care Board to come in and speak on some of the areas that we heard on yesterday within that bill.
Thank you for having us. For the record, my name is Owen Foster, I'm the Green Mountain Care Board.
And I'm Emily Brown. I'm the executive director at the Green Mountain Care Board.
Would you like us to just provide an overview? Ms. Brown and I will divide up some of our comments, and I'll try and go through it sequentially. The first section that I want to address is the Board of Directors and the changes to the composition of the Board of Directors.
We actually were so intrigued by all the other sections yesterday that we never got to the Board of Directors.
That doesn't sound familiar.
Maybe we can have you, or you can just speak to it in general.
Great, this is my favorite section.
But there's a section on Board of Directors.
Board of Directors of.
Spoiler alert,
Of the
everybody.
domestic insurance company.
Of a domestic.
What section are we in?
Okay.
4513A.
So
Yeah, here.
What
this is
section
a
is that?
Section 1.
section 1, and this is the board of directors for essentially Blue Cross Blue Shield of Vermont. Only domiciled.
Correct. The change that this bill introduces on the board of directors is it changes the composition of who is on the board of directors. That's a fundamental change. Section C in this bill, representatives of the public, C1, calls for 2 voting members of the board, but no less than 1/6 of the board to be representatives of the public appointed by the governor. So this would add a layer of, remove it just from self-selection of the board or of the board's management in who is on the actual. Why I think this is important is because it will create more diversity on the board. It'll make it so that people are not just selecting, friends and colleagues. It'll add a layer of transparency because it's people who are appointed literally by the political branch. I also believe that what we've seen in some of the governance issues across providers and insurance companies are unsatisfactory. My main gripe with the board oversight that's existed in Vermont is it has not been consistent with the state's goals in healthcare. What I mean by that, is we're seeing a lot of really large bonuses and executive compensation increases at a time when the state's healthcare system is literally failing. And I struggle with why are the executives of our largest nonprofit systems receiving enormous bonuses while the rest of the state is really, really struggling and suffering. And I understand it. It's because of their process. Their process is, here are the benchmarks, here's what we do, approve it. It's considering really just what's happening with that one organization, not what's happening to the entire state. So let's go to UVM, the easiest example. The UVM CEO, like 2 years ago, got a $600,000 bonus. Well, they did so in part because they had really good financials that year. From that organization's perspective, that CEO had done an outstanding job. They did really well. They made a lot of money. That lot of money came at the cost of a lot of other people paying a lot of money and a lot of other people not being able to get enough money for the services they provide. And I'm talking about community providers and primary care providers. So I think that we need to change how the board is looking at and evaluating its management. I think this provision does that. You need to consider the state's healthcare goals, not just how your entity is performing. My other concern here, and the reason why I support it, is we're all well aware of some Blue Cross's financial challenges that they had in the last couple of years. Their finances were truly nosediving. At the time that their finances were nosediving, the top executives had enormous compensation increases. In the Green Mountain Care Board's budget order, rate review order for Blue Cross, we noted, I believe the amount was a 40% increase in the CEO's compensation. So keep in mind, the Blue Cross insurance premiums are really high, the increases were exceedingly high, and their finances were nosediving. I do not understand why an executive would get a 40% pay increase over 2 years in that dynamic. It makes no sense. What I believe is correct is if the insurance company does a great job, rates are kept low, their solvency is good, that's a situation where you might say, hey, you're doing a good job, let's pay this person more. I'm not necessarily against high compensation. It's maybe a necessary evil at times, but it doesn't make sense to me when the system is really, really struggling. I think these changes allow us to have a little bit better oversight and input on that at the board level.
It says that the governor gets to pick 2. Should the governor get to pick 1 and the legislature pick 1?
Or
I
it
have
could
a
be,
problem with that.
don't. It could be the governor picks 2, the legislature picks 2. So I support the way the Green Mountain Care Board nominating committee is done. I think it's 2 from the governor, 2 from the legislature, maybe 2 from the business community, something like that. I forget exactly what it is, but it's different assortment of people making selections.
I think it's that, it's different. And then the nominating committee makes the decision on who to send up to the governor, and he may pick from amongst those choices.
Correct. Yep. No, I would have no objection to the legislature having appointments as well. I think diversifying these groups is really beneficial.
Go ahead, Brian.
Besides wanting them to be members of the public, are there any other guidelines that you might recommend? For example, there has been talk in the past about having a healthcare provider on the Green Mountain Care Board, and there's been bills saying that at least one of the members should be a healthcare provider. Might we want a healthcare provider on the board? Might we want a patient? Like, are there any other perspectives you might suggest we weave into these into these community-based appointments or appointees. Yeah,
Yeah, I think that is healthy. And at the care board, we do have a provider on the board and a physical therapist, and we have pretty good diversity now of professional backgrounds. And I think it is really, really beneficial. If you look at section B,
Mhm.
It also speaks to the composition of the board. At least 3/4 of the board of directors shall be composed of subscribers and members of the public. The remainder may be providers. So it gives them some discretion there.
which section was that? I'm sorry, I missed it.
Yeah, and I know it's hard because
Page
we
three.
didn't walk through
You
this.
didn't.
Yeah, bottom of page 3.
When we invited our guests
see it now.
in,
Okay.
the intent was that we had already gone through this.
So I go by the statute numbers, but so it's 4513A, section B, and then section C. Section B is the one I just referred to that talks about 3/4 of the board must be members of the public, including subscribers. And then section C is the governor's appointment.
Thank you.
You get a question of this, all hospitals have the same amount of board members?
No.
No.
And this bill is just as to the insurance company.
Okay.
Anything on that? Do you want to talk about executive compensation?
Sure.
Okay, I didn't, unless you don't have any thoughts on it.
No, my second favorite section.
Okay.
So this goes to my point that I made earlier about incorporating the statewide view when boards are deciding executive compensation. So this is 4513, section E. Starts with guiding principles for representatives of the public.
4516?
Page 5.
Page 7,
Page 7, 4516A.
4516A,
Is that?
number 13.
Yeah.
If it's page 7, line 13, I'm looking at the right spot. Thank you.
Right.
Okay.
So this, I support this section because there's additional transparency in how executive compensation is being, decisions are being made. So here it has a provision that requires the benchmarks that are used and the compensation surveys that are used to be provided to the Department of Financial Regulation so they can actually review them and say, hey, does this make sense? Not all of the surveys they're very different. There's a lot of different surveys that have different peer groups and different considerations. You can, I'm not suggesting they are, because I don't know, but you can cherry pick which surveys you like the best, and you can have a mismatch. So for example, and I'm making this up, but do these surveys include consideration of the financial performance of the insurance company? Did the surveys that were used when the executives had very large increases the last 2 years consider other companies that had the same financial trajectory? Did they consider that the rates were really, really high and the premium increases were high? I'm going to guess probably not, but this allows a layer of transparency for people to consider that and just take a more holistic view as to what we are doing on the executive comp, because it does matter. Executives are rightfully motivated by their incentives and they want to do the right thing. So we need to make sure that we're incentivizing them towards the right thing for the state. That's the key for me. And then it provides page 8, line 18, that the commissioner of DFR may require the insurer to modify who the peer groups are and can change it if they think that it's inappropriate. I think that's just a good oversight. It keeps everybody on the same page. I'm going to skip ahead to the age rating.
I'm waiting with, this is my favorite section. Favorite,
Before we get to that.
yes.
Um,
Oh, did you, I'm sorry.
Just waving.
you mentioned when you were talking about the board, the 2 public members. They have to be on compensation committee, which I think is important.
I believe that is correct. The compensation committee can have other people, but those members of the public must be
Have to be on.
correct.
Are we on page 11?
And you support that.
Do.
11.
Section 6.
Wait,
Age rating.
Age rate.
oh, we skipped ahead. Okay, I'm sorry. I thought we were still talking about I was still stuck on salaries. All right.
Okay, age rating.
Age rating. Right now, Vermont does not allow age rating, which effectively ends up meaning that people who are really, really healthy tend to pay more for insurance, and people that are sicker or older may pay less. The way it sugars off is older people who use more health services or maybe more ill get a better deal, and people on the younger spectrum and healthier get a worse deal. That's effectively what happens with this policy direction. What DFR, I believe, is proposing in this bill is to allow a small change to allow some age rating to happen. I believe they put a threshold of it can't be more than a 5% change that would happen. I do support this. And the reason I support it is because if it's more expensive for the younger people, the pool of people gets sicker because those healthy people drop out. And that actually makes it more expensive for everyone that's in the pool. You want to make sure you're encouraging and keeping those younger lives in the pool. And when we see people dropping this year with the loss of the enhanced subsidies and our really high costs, we're losing those lives, so when the board gets a rate every year, one of the biggest drivers, if not the biggest driver, is how sick that pool is. So a lot of people think, well, board, do a better job on the hospital budgets, and that's where we're going to find affordability. But that's not really true. I mean, there is a degree of that, but also you can't do anything about how sick the pool is. They need services. They cost a lot of money. If you don't have those healthy lives to balance out those sick lives, it's really, really expensive. I think last year, the morbidity adjustment, which is how sick the pool is, was 7%. A 7% increase just because how ill the pool was. So if the board keeps the hospitals, we can cut the hospitals all day, and that won't change that the base increase was 7%. And then last year, the CTR, the contributions to Blue Cross's reserves, how much they're going to put back in the bank for safety, really, that was also a 7% request. That means before we do our work, we're at 14% increase with nothing we can do about it, really.
Do you think 5% either way is incentive enough to actually change behavior?
That would be caveat I have with this is I don't think I've seen or heard of any data suggesting that this will actually change the behavior. So if you're considering this, I would ask for what's the data and the actuarial analysis that shows how much this will drive change. So should it be 10%? Should it be 0%? It's not going to drive change. Why are we doing it? So I would want to see that.
Yeah, I think I'm struggling, and I see you, Brian. I think I'm really struggling with, thinking about, okay, 5% if you're a little bit older, you're going to probably pay more than the benchmark by the rate that you set. 5% if you're younger, less if you're younger. But I'm also struggling with how the subsidies are affecting the younger. And, if we hurt one, help another, I can make those decisions of who am I going to help, who am I going to hurt? But if I'm looking at the one that we think we're helping, and we aren't maybe helping them, then we're like not helping somebody and hurting somebody else. So I'm like really struggling with this.
Exactly. The caveat that I would have is I would want to see the actuarial analysis of what that does.
I think if you could show that this policy change would bring more uninsured younger folks into the market, right? And then you could see, to your point about the subsidies and who they would be impacting with this policy change. I think those are all questions that should be answered. But again, if it has the intended impact of bringing more young individuals, healthier individuals into the market, and then, with the subsidy coverage, has a minimal impact on those older folks, then you might be able to justify it. But again, I think there needs to be an analysis showing how in Vermont this policy would actually impact individuals who are currently covered in the QHP market.
Brian, and then Leslie.
If it sounds like the point of age rating would be to incentivize participation in the marketplace, if we want to call it that. I don't like calling it that, but it's what it is, by younger people to reduce the risk or reduce utilization in the risk pool, to add their share. Are there other policy levers we might be considering that would achieve the same goal? For example, just gonna throw it out there, a small tax on all income earners that goes into a pool, and then we all just get primary care. You know, so then it's incentivizing people using primary care at all ages, which then reduces spending on the, you know, versus like these high deductible, where the incentive is, oh, you get 5% less on a plan that you have to spend 10, 12 grand on before you even get the benefits, you know, like that doesn't seem very appealing as a young to middle-aged person, you know, and yet I'm doing it because of the subsidies, you know, it's like, what, I don't know what that difference is gonna make when you still have a $12,000 deductible before it even kicks in.
Or increase Vermont premium assistance.
I think that these are all good policy discussions to have. But I would say, yes, there is a number of other policy levers you can use. The QHP plans have the market has gotten shrunk quite a bit. We've seen a lot of people go to level funded plans into the employer sponsored plans. That's decreased the pool. It's cannibalized the pool, and the pool that's left have been the healthier lives. If you wanted to create a healthier pool, you could require them to be in the QHP plans. That would make a bigger market. It would have more healthy, younger lives in it. The downside to that is those folks that are in those other plans now are getting a relatively better deal than the people in this pool. So you're going to be making a trade-off where those people would have fewer options that might be cheaper, but for that other pool, it would be better for the whole. And your point about primary care, there are a couple of primary care bills. There are some things the board is working on with site neutral billing and with reference-based pricing, where we're doing some things towards trying to ensure we get better primary care access. Also ties in well with the Rural Health Fund and some of the work AHS is doing there to bolster primary care. Certainly, I think improving our preventative care and overall health will drastically improve the quality of the pool in terms of health. Emily, did you have anything?
No, that was great.
Leslie.
I don't know if you're gonna get to association health plans, and maybe you will, but yesterday when we heard from PFR, there's like this tension between the association health plans in terms of where lives go and the age rating. And you mentioned actuarial analysis. Do we do that? What's the order of operations here in order to think about this? Because I feel like we're being asked to think about this with no data and no analysis. So what comes first?
So, again, this is not our,
I get it.
this is a piece of impacts the QHP market rates, which we regulate. But I do believe understanding the Vermont market and the impact of this policy on Vermont. I heard yesterday in testimony, I know that a lot of other states do this. I think Vermont and New York are one of the two states who don't allow age rating. But again, we are different and smaller than a lot of other states. So I think, again, understanding how this policy would specifically impact Vermont based on our uninsured rate, based on our subsidy levels, based on our existing exchange population, all those questions are important to have answered before you decide if age rating actually, you know, the 5% limit is actually going to, as Chair Foster said, change that behavior, bring more folks in the market, and what the actual impact on people will be.
So that makes sense to me because I'm
Yeah.
struggling with that. So thank you.
Yeah.
We can move to the association health plans if that's.
My second favorite.
So this is a similar discussion. Our view is also similar. I wouldn't say that we're necessarily for or against this as, you know, a policy lever, but the thing I would say is we should really consider what the pros and cons are. And one, it will hurt the pool in the QHP. And that's, I think, sort of the point, is that you're providing a more affordable set of options to the people in the QHP plan. So some people who can leave will leave, and they'll have a better, more affordable option potentially. The people that don't have that option and are left in the pool will see increased morbidity and illness, and that makes it more expensive. So again, it's a trade-off. Are you going to provide options for some? It's like the level funded plan, same thing. Or are you going to have the pool larger and overall more affordable for the group? That's really what you're deciding.
Shouldn't our focus be, I mean, we know we want to grow the pool. And we've got one age rating, which we think, oh, it'll grow the pool. And then we've got association plan followed up, which is going to shrink the pool. So there are complete odds to what the goal is. But I think the goal is we want to grow the pool. Because the more lives we can get into the pool, the more it's spread across, the risk is spread across more people. Shouldn't we be concentrating on how do we grow the pool? And how do we make that pool the pool that people want to be in. What can we, I don't know, I keep asking philosophical.
Oh,
Yeah.
I think, what are we doing to make that pool be attractive?
I think
So
if-
people don't want to go away.
I think if your goal is to make the pool stronger, more folks in it, as Chair Foster said, association health plans would allow some employers other options. It would take small employers out of the QHP pool and put them in a separate plan. So that would shrink the pool. So if the goal is to grow the exchange market, grow the small employer group market, this HP option, while it would provide some employers a less expensive option, it would not, if the intent is to grow the pool, it would not do that.
there's another consideration to throw out, which is what is the pool we're trying to grow? I think from the policy perspective here, it could be we're trying to grow the pool in Vermont of more young people and having more affordable other options like AHPs. While it might hurt the QHP pool, might help the overall Vermont demographic pool. But again, I think the point is the same. I would want to see the data on how much this will help or hurt. Same with the age rating, like how much is this actually, do we actually anticipate? Because the actuaries do a really good job of giving pretty good numbers that show what this will do. I do think that overall growing the pool, right now it's a pool of last resort. I mean, that's what it is. It's a pool of last resort. And that's really tricky. You have to think about who's in that pool. It's a lot of carpenters. It's a lot of tradespeople, right? It's people that don't have another option. And that's a really important pool to make sure they can afford healthcare. Because one, a lot of people, they have health needs. And second, they're really important Vermonters.
And it's small businesses.
Yeah, exactly. Restaurants, nonprofits, a lot of the backbone of our main streets.
Thank you. What would be the projected time frame where we may see a result if we would choose?
I think that would be better asked to DFR. They would be the ones that would have better granularity on that. I don't really know.
And so you can only enroll in the QHP once a year.
Right.
So if this change was implemented for rates for 2027 plan year, you would expect there to be some impact. Yeah, but it would probably be a gradual impact. But again, I agree. I think DFR would be the better entity to answer those questions.
And if it was positive, would you increase that number, 5%? Eventually, is that how it would work?
Positive.
If the 5% made the pool larger?
The cost change.
Yeah, would you
Then
increase?
you also have to think about okay, if it's 5% good for one, it's 5% bad for another. So if you're gonna make it 10% great for somebody, it's gonna then get 10% worse for somebody else.
And I think that's what
That's
the
why-
analysis could show you, right? You could measure different thresholds of premium increases, and then what the actuaries can do is they can actually model, not necessarily to 100% accuracy, but they can kind of show you what the projected impact would be.
We did yesterday ask for a timeline from DFR of all of these proposals, so I'm hoping they bring that forward. Sorry, Jennifer.
Topper, did you have a question? Daisy, did
Well, I
you?
just gotta say, in order to do that, you're gonna have to change the bill. Because right now it limits it
Right.
5%.
I sort of got the feeling as we were going through this yesterday, that a lot of this stuff is theoretical and I don't know if anybody else was a little frustrated with, well, we're not sure.
It's a lot of probable,
Maybe probable. And you've actually mentioned this in your testimony today, that, we need better numbers. I hate to throw this out here because it seems to be one of the things the legislature does best.
No, I know where we're going.
Should we perhaps, I'm not making the recommendation now, but it's a thought swirling in my head. Would you be supportive let's look at it. Let's come back with an analysis.
My response to that would be, let's see if we can get any better information now. I mean, I do think that there is quite a bit of urgency to all these issues. I think this is one where it's possible to have the actuaries get on it pretty quickly.
What's quick?
I mean, when we work with our actuaries on these types of issues, we can get it 2 to 4 weeks.
Yeah.
We have crossover. I mean,
So I think the age rating question is a quicker response time, because we have data on our exchange right now. We know who's enrolled. We can measure that. I think for the impact, I heard yesterday, the impact of the AHPs and the short-term limited duration is a lot more harder, if impossible, to measure, because you don't know who or which employers in the market would want to pursue that option. It would also involve a rule change. We have a rule right now that is fairly restrictive towards AHPs. So that I think would be harder to measure as far as impact on which employers are going to choose that option. There are already some AHPs right now. There's Veda, right, which was mentioned yesterday, but there's also other options for small employers who have healthier lives that they've already taken. There's the Blue Edge program, which exists right now, that has taken that some small employers have the option to pursue. So it's hard to understand what other option for AHPs, because of the ERISA requirements around how those can be formed, what impact that would have in Vermont. And maybe DFR has had interest, and so maybe they could, maybe they know of some, potential associations that want to form. I have no idea, but I think that would be harder to measure the impact, because you just don't know who is going to be successful in the pursuit of an association.
And just to let everyone know, for timing's sake, we're going to reschedule Blue Cross Blue Shield, because we want to make sure they have a lot of time as well. So we're going until Daisy.
You said something about urgency, and that's always something I really look to you for, is how urgent is this? We did a lot of regulatory changes last year, and I have heard from some providers, let this dust settle, let us implement some of these changes. They're huge. We need to catch up. So do you have any concerns about anything in this bill, adding it to the existing things that we're doing around healthcare reform and hospital transformation, and whether that would muddy the water or?
Well, as to this bill, I don't really see this having too much impact on the provider side. It's really focused on the insurer side. There's one provision, actually 2 provisions we could talk about that are more focused on providers, but in terms of the provider concern of moving parts, I don't see that as being an overwhelming concern in this bill. I mean, if you change to a limited age rating, that won't really impact the providers. It won't add any red tape or any burden for them. It'll change something for the insurance company.
I don't think site neutral billing would have okay. We'll get to that later.
There are 2 sections I do think impact the providers more.
And then I think to address that question specifically to the AHPs and the short-term limited duration, I think it depends on how those policies are enacted. So if we're thinking about short-term limited duration, for instance, right now, any short-term limited duration plan in Vermont can only be offered for 3 months. The benefits need to be similar to those for the essential health benefits, which are similar to the QHP market. This policy, I'm understanding, would expand the availability of those products. There's a rule also. So it depends largely on how these policies and how these rules kind of sugar off in the future. If the benefits are the same as they are now, you would expect then when a consumer buys one of these products and then goes to their doctor, they would have similar coverage. I think what I think about is, if the short-term limited duration benefits end up being less than what they are now, how does that impact access to care? Meaning you then don't have insurance coverage when you go to the hospital for certain benefits that right now under the existing short-term limited duration policy you would have. So those are the kind of like downstream impacts that are unknown. Like there's not an answer because they're not in place right now. So I think it's hard to answer what the impact would be on our hospital, or on our healthcare system rather at large, without knowing more details. I don't know if that is, if that
Yeah,
was clear
I'm just,
enough.
I'm really listening for a sense of like, you need to implement some of these changes now. Because that was the message all last session, right? Is the house is on fire.
So the health is on fire, meaning our healthcare costs are too high, right? And legislation passed last year, a lot of authority given to the Green Mountain Care Board, to AHS, was intended to try to control those costs. What I view largely as these options doing is creating more options, creating more alternative coverage options for individuals who, because the enhanced subsidies went away, for instance, they now maybe want an option to buy a short-term limited duration, or maybe an employer says, I can't afford the exchange, I want to do an association health plan. So this creates more coverage options. I don't see it addressing the underlying healthcare cost issue that a lot of legislation last year that was passed is meant to address. And Chair Foster, please chime in if I'm.
Yeah, I totally agree. Two things. One, I think the bills you passed last year were house on fire bills, and they were immediate, right?
Yeah.
The drug price cap was immediate. The 482 bill passed out of this committee to provide for insurance protections for downside, immediate, right? Those allowed us to immediately last year reduce the rates of insurance. They were hugely impactful in our ability to reduce the QHP increases. These do not do that. These are more longer term structural things. I don't view these as necessarily like going to solve a house on fire problem, but they do help with the longer term solutions.
They may help individuals' houses that are on fire because they can't buy groceries because their premiums are so darn high.
Well, it may be in a year, right? They're not necessarily going to do it this year, potentially. But people have to get on, they have to sign up. It's a whole process before that would actually happen, as opposed to immediately reducing the price of the service.
And then some of them were hurting others.
Correct.
That's
Correct.
the tough part.
I think I'm asking this question. I might be asking this question maybe more to Emily, because I know you have experience in this, but we're sitting here with a DFR bill and we're talking about, okay, the house on fire. And again, yesterday, I just kept getting the feeling of, we got to throw something at it. So let's just throw all these things at it, not without really any evidence that they will do anything. But again, I keep thinking about how do we make it more attractive for more people to get into the pool? And from the regulatory side, is there something with our benefits we could do? I mean, we have very few choices of plan options, and you were talking about it gives people more options. Is there something that we can do within our QHP market to actually provide more affordable options? Are there some levers that we can push in that regard to actually make them more attractive and give more options?
So there are a few things that come to mind. Right now in our QHP market, and Diva would probably be the best to speak to this, there are non-standard and standardized plans. The non-standardized plans, it's my understanding, are designed in a way to try to be attractive to folks maybe with certain health conditions, or guide them towards less expensive care to try to mitigate some of those high cost services that they would maybe have to use if they weren't accessing preventive care. So I know there are options there. And again, that's a policy decision that I would defer to Diva on. I think in our existing statutes, we have a lot of health insurance mandates. So we require insurance companies who want to operate in the regulated insurance market in Vermont. That's the fully insured market. So when you think of QHPs, they have to offer certain benefits, and those are all outlined in Title VIII. And I'm speaking with my former hat on right now.
That's why I asked you, not Owen.
Yeah, and so I know from my time at DFR and previous legislative sessions, there has been an interest in looking at the whole environment of all of our benefit mandates and understanding the cost impact of those mandates. And then also not only the cost impact, but then actually, are they designed in a way to be guiding people towards the preventive care, the lower cost services, what is the actual benefit or the impact of the cost of that benefit? And then is it actually designed in a way that's making people healthier, right? That's the goal. You want to ensure that people are having access to services that are, balancing cost and the actual, usefulness of that benefit. So I think looking at our state mandated benefits and understanding the cost impact of those on our QHP and fully insured business would be a worthwhile exercise. That could be one thing you could look at.
This is a good question. Something you said made me think of when I was looking at the QHP market this year and trying to pick a plan. So hard
Yeah.
to understand. So do you think people are even in the right plan for themselves?
I can't answer that. I have no idea.
Right.
Yeah.
Because I mean, yeah. So there's so many options and it's like,
Yeah.
I don't know which one is better for me. And
Yeah.
all right, thanks.
Sharon, did you have a question?
Yes, when you talk about the mandated benefits, are you just talking about the QHPs now, or are you talking about all of our Vermonters insured in all?
No,
all
so
the different?
Yep, so there's what's called a regulated market in Vermont. And so in Title VIII, there's a chapter which outlays all of the mandated benefits that if you want to offer coverage in Vermont, you have to offer.
Yeah.
So
That's system-wide.
correct, except the self-insured, the ones that are regulated at the federal level.
Did you want to speak to any more things? Did you have?
Yeah, to follow up on Representative Rebecca's question about the provider burden.
Oh, yeah.
There are two sections that I would look to on that, and it's on page 21, the prior authorization component. And then I'll also speak to the site neutral billing on page 22. 21, prior authorization change. This narrows the scope. So I think the legislature 2 sessions ago made it that any primary care provider that was ordering something didn't need a prior authorization. This reins that in a little bit where it's only non-hospital primary care providers. I think the intent is to get around a potential loophole where hospital-based primary care providers can get a request from a specialist. And if you run it through them, now that you don't have to get it. So I think this does help with the insurer solvency potentially. It does give them a prior authorization is a tool they use to make sure that there's not unnecessary utilization. We have seen utilization increases across the state at hospitals in the last couple of years. So I do support narrowing this. I don't know sitting here today how big of a problem it is. I haven't seen data suggesting that the hospitals having this as well is a huge, huge problem. I do know that we haven't seen data indicating when you pass this, I believe there is an intent to reduce administrative costs. We haven't seen those administrative savings materialize yet. I don't think there's been the report and we haven't seen it in our budgets. So I would support this change. It is a protection effort to keep healthcare costs down, and it's minimal. You can then see how it works with the independent hospital primary care providers. And if you need to expand it again, you easily can. Sorry.
We're kind of tied to this.
Yeah.
Just like.
Sure, we'll just do it again. Took 10 years off my life. But okay. Moving on.
Site neutral billing on page 22. This is one that we do not support. The reason we support the concept, we believe site neutral billing is an appropriate tool that the state should be going towards. And a lot of the care board's regulatory efforts have been made to equalize the rate of increase for payment for non-hospitals and for hospitals. What we saw in previous years, we were hospitals getting 8, 10, 12% increases on commercial price and everyone else getting 0, 1, or 2. Through our regulatory efforts, we've really made that much more equal. And I think in last year, the non-hospitals were actually maybe a little bit above the hospitals. So we've done a good job through the regulatory structure of doing that. But your problem is the base expense on which we've equalized was really, really high for provided hospital services and really much lower for the non-hospitals. So the concept, I think, is the right concept. We want to make sure we have these non-hospital providers that have great quality and access available throughout the state. That is, in my view, one of the fundamental problems with our health system is care has been concentrated in hospitals. I've spoken about that a number of times here. The reason that I do not think that this provision is necessary is because it overlaps with some of the work done in Senate last year, Senate S-126, forgetting the act number that ultimately became.
Act 68.
68, yes. And so because we're already working on that, it's subject to rulemaking. This is an effort that we're already working towards. And second, I think it's a little bit awkward to put DFR in this piece. So with Act 68, it's the board's responsibility. We have the rate setting authority. We always have. So having to do it with DFR gets a little bit awkward because they're not also doing the hospital side of it. So I do think it's superfluous, although we do support the concept. The other point I would make here is that insurers can already do this. They negotiate contracts with hospitals and with non-hospitals. And we do get to a point where I think the legislature and the regulator are doing a lot of the work that I actually think the hospitals and the insurance companies should be doing. So I don't know, there's nothing stopping Blue Cross from already saying, hey, hospital, you're going down and we need to increase the payment over here. That can happen. And I think it should happen. I will acknowledge that there are market disparities in power that have created difficulties for Blue Cross to be able to do that. I think that has shifted a little bit. I think the governance change actually helps with this too. Because if the Blue Cross board has people with more of the public interest, broader, and governor appointees or legislative appointees, they'll be pushing on this. And I think if you do the same thing on the hospital side, they'll be pushing on this because it's not just the interest of that one organization. So I think these changes together make sense. But I don't support adding this additional duplicative section. Emily, give your
No.
Oh, sorry. One other point I did want to make. I apologize. The first section of this says that the board and DFR shall identify outpatient or ambulatory services that are safe and appropriate to be delivered in low-cost non-hospital settings. I don't really know how we'd actually do that. We don't have a staff of like clinicians to say this one's safe, this one's not safe. And there's incredible complexity there. An MRI is not an MRI. An MRI for this procedure might need to be done at the academic medical center. An MRI for a different procedure can go somewhere else. So for us to do the work to figure that out would be very, very time consuming and costly.
Any other questions?
Probably a question you can't answer. We heard a couple of times yesterday that we're waiting for Fed rules to be able to do this or that. So you know what I'm thinking.
Yeah.
Common something, whatever that is. You have thoughts about that? I mean, we do it anyway and have it prepared in case the rules change or not change, or, I mean, what's the downside of doing or not, and you may not know.
Are you talking about the association health plan?
Yeah, but it came up
specifically?
other places too, but that was the common something clause. I can find it.
I think, yeah,
I'm not sure with the
it's definitely around the association health plan.
Your
Commonality test.
commonality test, yes. So history here is that during the first Trump administration, they changed the association health plan rules to try to open up the market. There was then a court decision that what they had done at that time was not legal. So that federal rule was then put on hold. The next administration, I believe, went back to and reverted to the prior AHP rules. And I believe it's now the intent of the second Trump administration to, again, try to expand that test that you're referring to, the commonality of interest test.
Yeah.
That is a federal, I understand it's a federal test that needs to be complied with to create an AHP. I am not aware of where in the process that is. I'm just not tracking that. So
Yeah, my question is more about, does it make sense to enact legislation based on a potential federal rule someday, maybe? There's probably no answer.
I don't have an
but,
answer.
I don't
Yeah.
know how to proceed with this uncertainty, I guess, thinking about that. Thank you. Sorry to put you in the spot.
Thank you. Thank you. Thank you so much.
Thanks, Pat.